Greetings and a warm welcome to everyone. I am Ria, the assigned moderator from Clarinet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my deepest gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Clarinet. It stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. The topic for today's session is early diagnosis of endometriosis in adolescents, bridging the awareness gap. Now, I would like to extend a special welcome to today's esteemed speaker, Dr. Sumati Saxena, ma'am. Dr. Saxena holds the degrees of MBBS, AMS, and she is a senior consultant at Dr. Sumati Saxena's clinic. With over 30 years of clinical experience, she is known for her extensive expertise, patient centric approach, and commitment to delivering high quality evidence based medical care. We heartily welcome you, ma'am. And without any further delay, I'm handing over this session to you. Kindly proceed with your talk. Over to you, ma'am.
Thank you for the warm welcome and good evening, friends and delegates. Happy Republic Day. The topic for today's webinar is early diagnosis of endometriosis in adolescents and bridging the gap by recognizing pain early, restoring normalcy, and preventing delay. So, today we are addressing a critical failure in women health, that is the diagnostic delay of endometriosis in adolescent. And now I will discuss why this gap exists and how adolescent pathology differs from adult and the modern strategies to bridge the gap between the symptom onset and relief. So endometriosis is a chronic inflammatory condition characterized by ectopic endometrial tissue, and it is a very common condition, but it is underdiagnosed in adolescents, and the diagnostic delay is as long as 7 to 10 years on average, and early recognition can change the disease trajectory and preserve fertility. As you can say, if you there is onset of symptoms and if there is diagnosis delay, it can lead to complications, and there are long-term implications also in the form of infertility, mental health issue, and chronic pelvic pain. Up to 50% of teens with chronic pelvic pain have endometriosis, and symptoms often dismissed as normal period pain. So why focus on adolescent? Because adolescence is a critical window for early intervention and education. The gap is between the onset of symptoms and the diagnosis, and this diagnostic delay is about 7 to 12 years. And the reality is that the onset often occur at menarche. Menarche means the first menstrual period, but the diagnosis often waits until late 20s. And the consequences are years of unmanaged chronic pain, central sensitization, that is nervous system rewiring, and school absenteeism, and social isolation and potential disease progression affecting fertility. So there are multifactorial delay. Delay is because of lack of awareness in patients, parents, and among the physicians also, and misconception about adolescent dysmenorrhea, and there are limited non-invasive diagnostic tools, and because of this their result is disease progression before recognition. So clinical diagnosis is key. Imaging may be normal, so you have to focus on the clinical signs and symptoms for the diagnosis of endometriosis in adolescents, and you have to focus on pain pattern and the quality of life impact, for which you have to take detailed menstrual history and pain history. And family history of endometriosis is very important, because if there is family history of endometriosis, then it increases the risk of endometriosis in this adolescent. So there is importance of clinical suspicion, and the criteria for clinical diagnosis are: the red flags for immediate action is the non-steroidal anti-inflammatory drug resistant. that the pain is not relieved by the ibuprofen or naproxen, and absenteeism, missing school or activities due to periods. And family history increases the risk by 7 to 10 folds. And early onset, that is severe pain, is started within the 6 months of anarchy. And if all these are present, then assume endometriosis unless proven otherwise. So clinical diagnosis is very important. And adolescents are not small adults. Adult presentation is in the form of the disease presents in adults in the form of cyclical pain, that is worse pain with menses, deep pelvic cramping, and on laparoscopic there is powder burn, that is black blue lesions. But in adolescent, pain may be cyclical or acyclical. Acyclical meaning that pain occurs anytime, not just limited during the period. And there is GI dominance. There is dominance of gastrointestinal symptoms like nausea, bloating, and painful bowel movement. And lesion appearance on laparoscopy are clear red or vesicular lesion, and which are often missed by the untrained eyes. So investigations are have limitations, like ultrasound may miss early or superficial lesion. MRI is helpful for deep infiltrating lesions, and diagnostic laparoscopy is gold standard, but it is an invasive procedure. And need for biomarkers and better imaging sensitivity for early diagnosis. So the role of ultrasound is that it is a first line investigation. After the clinical examination, I advise patient to go under ultrasound. And ultrasound transvaginal is gold standard, but it can be transabdominal for virgins or transvaginal if appropriate. And you have to look for adnexal masses, endometriomas, which are less common in teens, or obstructed outflow tracts, which can lead to endometriosis. So that may be the cause. And the caveat is that a negative ultrasound does not rule out endometriosis, because superficial peritoneal implants are invisible to ultrasound. And MRI is helpful for deep infiltrating endometriosis or for mapping of the lesions before surgery. So for bridging the gap, early recognition is important, for which there are certain strategies. And first of this is education. Education means awareness, and in the form of menstrual health session in schools, and awareness among the primary care providers, and empowerment of the girls to report abnormal pain, and parental sensitization is very important, and early referral of the non-responder patients to the gynecologist early. And the role of clinician is to take the adolescent pain seriously, validate and listen empathetically, initiate empirical therapy in the form of NSAIDs or oral contraceptive pills while evaluating, document response, and if the response is poor, investigate for the endometriosis. Use shared decision, making the patient and family both are involved. So empiric therapy as a diagnostic tool we can use. And what is that? That is start hormonal suppression in the form of by giving oral contraceptive pill or progestins without surgery. And logic behind this empiric therapy is that if pain responds to hormonal suppression, it supports the diagnosis of endometriosis. So the benefit of empiric therapy are that it stops the cycle of pain immediately, preserve fertility potential by suppressing active disease, and avoid surgical risk in mild cases. And you have to consider surgery when needed, and the role of surgery is that it is gold standard for complex cases of failed medical management cases. And the visual challenge is that surgeons should be trained to spot non-pigmented, that is clear or red lesions, because the normal trend is that there is a black lesions seen on the laparoscopy but in adolescent these lesions are clear or red. So you have to identify them clearly, and the technique is to excise the disease, not ablate, because by ablation there is high recurrence rate and often ineffective on deep lesions. And education of school nurses, the front line of trials, tracking absentees, and pediatricians who must move beyond, take some analgesic, and patient empowerment, validating that pain interfering with life is not normal, and the multidisciplinary care is required, involving all the other branches also. So, new horizon in diagnosis is on the research on non-invasive biomarkers, artificially intelligent assisted ultrasound mapping, menstrual blood analysis, a potential screen tool, and early phenotype for risk-based screening. But all these are under research and not applicable in practice nowadays. So, call to action is to break the silence around menstrual pain, train healthcare providers in adolescent friendly gynecology, include menstrual health in school curriculum, and encourage research and policy change. So, the key takeaways from this presentation are that endometriosis begins in adolescence, early pain is not equal to normal pain, and bridging the gap requires awareness, empathy, and early intervention. So, listen early, act early, and save her future. Listen to the patient, believe the pain, and treat early. And here are the references which I have taken during this presentation. Thank you so much for your attention. Thank you.
Thank you, ma'am. Thank you so much for the comprehensive talk. It was really very informative. So we have received few